So, but I like to simplify things. I think in the world you can make it as complicated as you want with all these valve procedures, or actually try to see if a simple procedure can get away from doing something complex. Okay? So, and I've been given the task of about alcohol septal ablation. I have no disclosures for this talk. And the anatomic reasons that we have seen in fantastic talk, we need to make sure that when we do valve and mitral, whether de novo or valve and valve, we have to look at what is the risk of LVOT obstruction, and it is a multifactorial problem, not completely solved just by improving the valve frame designs. There are several things here: annular size, small LV size, MAC, leaflet morphology, LV function and comorbidities, and sometimes transseptal delivery also could be a problem in the TMDR. So what is the risk of LVOT obstruction? Incidence is about 40%. It is in valve and MAC, much higher than valve and ring or valve and valve. But the leading cause of actually all the screen failures for these fantastic devices that are trying to come into the market with mitral valve replacements, and about actually, if you have LVOT obstruction, there is a 62% in-hospital mortality, which is much higher than even cardiogenic shock patients that we have. So what anatomical factors are fixed, whether it is a small or hypertrophy ventricle and neo LVOT less than 200. On iodomitral angle, I think Vinny has done a fantastic job and publishing that in less than 120. There is a much higher risk, 90 and above. There is absolutely LVOT obstruction in those patients. So, and long redundant anterior leaflet, what should be the length? I think more than 25 millimeters, and absolutely if it is more than 30, it is definitely going to cause LVOT obstruction. And it is catastrophic. LVOT obstruction in MAC registry, 69% actually caused LVOT obstruction that led to fatality. So let's look at number one. Alcohol septal ablation is much easier. Most of these patients have hypertrophic septum, especially measure the septum, and you can think about alcohol septal ablation in such patients. And as I said, this in Vinny's paper about iodomitral angle, more than 180, there is no risk of obstruction at all, and less than 180, less than 90, absolute risk for LVOT obstruction. And look at the AML length as well, and make sure that you can assess that as well before you plan. So LVOT, alcohol septal ablation, the way that I started, I'll show you the next page, is in post TMDR. But then actually now we are switching, as Saibal mentioned, to preparatory septal alcohol septal ablation. So this is the 83-year-old man, history of AVR, heart failure with preserved ejection fraction, severe MR. He was actually randomized to the Tendine arm in the Summit trial, which is a trial looking at the mitral TEER versus actually mitral TMDR with Tendine. And his neo LVOT measured at 260, so that's why he was screened as positive, and he underwent a Tendine with the 33 LSP device. So, but in the post of day 3, it was hypertensive. Well, I don't know, but you were screening them as well. We didn't have actually AML length as one of the things, right, in that. So, in my opinion, actually, we keep looking at it. There's an AML length as well as septal hypertrophy a little bit, but I think the AML is what is causing, as you can see probably here, that actually is causing the new LVOT obstruction. There's some redundant tissue there, okay? And so the LVOT gradient in this patient, whom we could not actually come off pressors, and the shock is about 100 millimeters gradient. And so as you can see, surgical valve and a Tendine here. So then we said, okay, let's do what we normally, as I said, do the simple things first. Let's try alcohol septal ablation. His LV was not as thick as the one that I showed you, so we went with a 2O balloon, 212 all the while balloon, and the septal S1, and we injected gradually. I always start with 0.5 ml, be very slow, 0.5, 0.5 in gradients and increments, and looking at the gradients. And so we delivered only 1.5 ml of alcohol, and the mean gradient actually, post-alcohol septal ablation, LVOT mean gradient came down to 4. And the peak gradient is actually 8 and 5, okay, by both by echo. And in post of day 4, just the day after, he was extubated and discharged home on day 7, and he went his merry way home, and we will make sure that we keep following him up for anticoagulation. So then we started looking at 3 and 2 alcohol ablation to prevent LVOT obstruction, and the great publication from Mayo Clinic looked at 22 TMDR patients versus 80 HOCM patients. And obviously, the septal ablation was used less in the TMDR group as compared to HCM. And we regularly do alcohol ablations for HCM patients anyway, but as similar way, and there's no pacemakers in, at least in our group of patients, because we're using very low dose of alcohol, I think. And but you know, in the TMDR group, the pacemaker use is actually about 35%, and complete heart block as compared to HOCM as only 23% or so. Okay. And so the neo-LVOT definitely increased in these people by about nearly from 135 to 233. So there's a 30-day mortality is also 0. So people feel that there's limitations of septal ablation in pacemaker, but if you do in increments, I don't think there's a big price that you're paying. And depending on arterial anatomy, sometimes there may not be any septal, or there may be 2 septals, and you have to use all of them. Even small 1 millimeter branches can do the trick, and it is easier to do. And it takes about 30 days, and you have to wait for that. Okay. So in this, actually another study looked at this in patients with high risk, the alcohol septal ablation increased the neo-LVOT from 85 to 111, so there's at least 30 square millimeters increase. So I'll skip that one. So there's definitely, you can reduce the septal thickness by a lot. But in the next one, this is a recent patient of ours. Unfortunately, the videos were not big, so I'll just tell you the scenario. 75-year-old woman with a third-time redo. She had an aortic valve and then the mitral valve with septal reduction, hypertrophic cardiomyopathy. So mitral valve was placed, and that mitral valve was the bioprosthetic mitral stenosis. And the neo-LVOT measured at 130, and aortic mitral angle is 114, septal thickness was 14. We said, you know, we presented in our structural conference and did a alcohol septal ablation. The peak LVOT rating was only 15, and it came down to 1. But after 1 month, we repeated the CT again, and neo-LVOT went up to 179. Septal thickness remained at 11, no VSPs. I think that is another fear that people worry about. In a normal thickness septum, when we give alcohol septal ablation, and that's why I'm showing this. And a successful valve-in-valve mitral with 26 S3, and this is she's been doing well for actually this is 1 year follow-up, and she's doing well. So in conclusion, this is alcohol septal ablation, as I said, is simple, universally available technique. You can just buy off the market the amount of alcohol you want.